Diagnostic errors represent up to 70% of medical errors, and they don't always happen because of a lack of knowledge, but because of the way we think and make decisions. Today we'll see what cognitive biases are, how they influence us, and what we can do to prevent them. What are cognitive biases? A cognitive bias is a mental shortcut. It helps us make quick decisions, but it can mislead us. In medicine, these shortcuts often lead to incorrect diagnoses. That's why we need to learn to recognize them. In clinical practice, we use two ways of reasoning. The first is empirical reasoning, fast, intuitive, based on experience. For example, a child with fever and rash immediately think of chickenpox. The second is logical reasoning, more analytical, step by step. For example, a patient with fever and headache analyze history, check for neck stiffness, and order a lumbar puncture to confirm meningitis. Clinical reasoning requires both. Empirical gives speed. Logical gives precision. A good doctor knows when to stop and reflect, and when to change strategy. This is where metacognition plays a key role. Let's look at some of the most common biases in clinical reasoning. 1. Anchoring. We stick to the first impression and don't change it. Example: a young person with chest pain, anxiety is suspected, and a heart attack is overlooked. 2. Premature closure. A diagnosis is accepted too quickly. Example: a postoperative patient with shortness of breath. Pulmonary embolism is assumed, but in reality, they had acute pulmonary edema. 3. Confirmation. We only look for data that supports our initial hypothesis and ignore what contradicts it. Example: when suspecting pneumonia, we value fever and cough, but ignore a normal chest X-ray. 4. Availability. We judge based on what we remember easily. Example: after seeing many influenza cases, we diagnose influenza in a patient who actually had endocarditis. 5. Framing. The way information is presented affects our judgment. Example: if a patient is referred as abdominal pain in an alcoholic, we think of pancreatitis and overlook appendicitis. 6. Ascertainment. Stereotypes or expectations influence us. Example: a patient with a history of drug use. Their abdominal pain is attributed to withdrawal, ignoring a perforation. 7. Overconfidence. Believing we cannot be wrong. Example: an experienced physician diagnoses pneumonia without ordering tests, missing the chance to detect a tumor mass. 8. Affective bias. Emotions influence judgment. Example: paying more attention to a friendly patient and minimizing the symptoms of a difficult or aggressive one. 9. Omission. Preferring not to act out of fear of causing harm, even when inaction is more dangerous. Example: not prescribing anticoagulation in atrial fibrillation due to fear of bleeding, which increases the risk of a stroke. What can we do to reduce these errors? 1. Practice metacognition, reflecting on how we think. 2. Perform diagnostic timeouts. 3. Promote team reviews and feedback. And 4. Explicitly teach about cognitive biases in medical training. We can summarize these strategies in the rule of the 4R. Reflect on your reasoning. Review with a diagnostic pause. Receive the team's opinion. And recognize biases by learning about them explicitly. Applying these 4 actions in clinical practice and simulation helps us improve clinical reasoning and provide greater safety for our patients. Cognitive biases are inevitable because they're part of how we think. But if we know them and reflect on them, we can reduce diagnostic errors and improve patient safety. Remember, Acknowledging uncertainty is not weakness, but a sign of clinical maturity.